OKC, that is Odontogenic Kerato Cyst, is also known as primordial cyst. So what is OKC? It is a cyst derived from the remnants of the dental lamina with a distinctive lining of 6 to 10 cells in thickness and exhibit a basal cell layer of Pallisaded cells and a surface of corrugated parakeratin. So it is a cyst that is derived from the remnants of the dental lamina and it has 6 to 10 cells in thickness and exhibit a basal layer of Pallisaded cells. The basal layer is made up of Pallisaded cells and the surface having corrugated parakeratin layer. So this is the OKC, that is Odontogenic Kerato Cyst. Next, moving on to the pathogenesis. The OKC arises from the dental lamina or its remnants. So it is arises from the dental lamina or its remnants and primordium of the developing tooth germ or enamel organ, and sometimes from the basal layer of the oral epithelium. So dental lamina or its remnants and basal layer of the oral epithelium, or sometimes it is developing tooth germ or enamel organs. Next, moving on to nevoid basal cell carcinoma syndrome. So what is nevoid basal cell carcinoma syndrome? It is a hereditary condition, and since OKC develop in association with this syndrome. So nevoid basal cell carcinoma syndrome, it is a hereditary condition and mostly, that is Odontogenic Kerato Cyst, develop in association with this nevoid basal cell carcinoma syndrome. So it is an associative condition. So this picture showing the nevoid basal cell carcinoma related to OKC, showing the nevoid basal cell carcinoma present on the face, and this is the X-ray features, chest X-ray and skull X-ray and OPG. Next, moving on to keratocystic odontogenic tumor. So what is KOT? Keratocystic odontogenic tumor. So OKC may be regarded as a benign neoplasm rather than a conventional cyst. So based on its clinical behavior, because it is not a true cyst, it is not a conventional cyst, but it has some potential to benign neoplasm. So it is called a keratocystic odontogenic tumor. All OKC are called keratocystic odontogenic tumor. All OKC cysts are not a keratocystic odontogenic tumor. So here the behavior is, in KOT is locally destructive and recurrence rate is very high. Locally destructive and recurrence rate is very high, and histopathology, basal layer of the KOT is produce proliferation and budding into the underlying connective tissue, and it produces daughter cyst and mitotic figures. So in genetic PTCH, a tumor suppressor gene involved in both syndrome associated and sporadic KOTs occurs in chromosome 9q22.3 and q31. So this is the chromosome involved in the keratocystic odontogenic tumor. So mainly if it has daughter cyst on mitotic figures, mostly it proliferation is higher, so recurrence rate is higher. It produces act as a KOT, that is keratocystic odontogenic tumor. Next, moving on to the clinical features. In incidence, 1% among all of the jaw cysts, it is presence of OKC, and age and second and third decade of life it affects, and most commonly it affects the male, and most common site of jaw is maxilla than the mandible, and in mandible it is mostly affect in the angle of the mandible and extend to the ramus and body of the mandible, and maxilla more anterior part of the jaw and less posterior part of the region is involved in maxilla, and in gingiva there is an extra osseous type. Next, moving on to the presentation. Here the in initial stage does not produce signs and symptoms. So in large lesion there is a swelling and facial asymmetry are present. When the pain is occur, there is a mobility and displacement of the teeth also occur. So it has 3 stages: in initial stage and large lesion and pain. The expansion of the bone. So expansion of the bone, 60% of the cases, maxilla, 1/3 of the cause expansion of the buccal cortical plate, and expansion of the palatal cortical plate is rare. So in maxilla there is a buccal cortical plate is most commonly expansion is occurred, and palatal cortical plate is rare. And in mandible, buccal expansion is 50% and lingual expansion is 30%. In gingiva, there is an extra osseous lesions presence in the gingiva, and multiple lesions are also present. It is called nevoid basal cell carcinoma syndrome. So multiple lesions of OKC called nevoid basal cell carcinoma syndrome. So here the maxilla, the expansion occur in the buccal cortical plate, and in mandible, here also buccal expansion is most commonly occur than the lingual expansion. In gingiva, it produces extra osseous type. If OKC is multiple lesions, then it called as a nevoid basal cell carcinoma syndrome. Next, moving on to radiological features. In OKC, multilocular radiolucent areas are present. It is called as soap bubble appearance. And OKC, there is a unilocular and well corticated margin, and mandibular lesions enlarge and extend to the other side of the bone also. So crossing the midline also, and the border is smooth and scalloped, and displacement of the unerupted teeth is occurred, and pathological fracture or perforation of the cortical plates of the bone is also occurred, and root resorption rarely occurs. So in OKC, it may be multilocular or also unilocular also present. If it is multilocular, it has soap bubble appearance. So this picture showing the unilocular appearance, there is a well corticated margin present, and in the most commonly in the angle of the mandible, and there is no root resorption because root resorption is rare, but displacement of the tooth is occur in some conditions. Next, moving on to the border. So the border smooth and scalloped. So the displacement of the unerupted teeth also occurred, and pathological fracture or perforation of the cortical plates of the bone is occurred, and root resorption rarely occurs. Next, moving on to the differential diagnosis. In differential diagnosis, definitely all the cysts, or we have to differentiate from the dentigerous cyst, aneurysmal bone cyst, and radicular cyst. All the cysts have some separate specific features. In OKC, we have to differentiate these features. In differential diagnosis, first one is ameloblastoma. It is a benign tumor, and dentigerous cyst. It also occur in the angle of the mandible, and aneurysmal bone cyst, odontogenic tumor, and lateral periodontal cyst. Next, moving on to macroscopic finding. On naked eye examination, OKC produces a cystic cavity, and it is filled with a thick cheesy material. If we aspirate, there is a cheesy material present within the OKC cyst, and some cysts are filled with clear fluid also. So cystic wall is very thin and friable. So cystic wall is very thin and friable. So naked eye examination, OKC, presence of cystic cavity and filled with a cheesy material. Cystic fluid, aspiration of the cystic content, it is a straw colored fluid. So straw colored fluid present in the OKC, and it contains 3.5 gram percentage of soluble protein. And cystic fluid measurement, there is a paper electrophoresis. We use paper electrophoresis for cystic fluid measurement. Next, moving on to histopathology. A cystic cavity, it is lined by uniform keratinized stratified odontogenic epithelium. Keratinized stratified odontogenic epithelium, that is 6 to 8 cell layers thickness, and the lining epithelium and connective tissue interface is very flat, and sometimes there is a V-shaped retipex formation, and acanthosis also present. And basal epithelium, there is a tall columnar cells or cuboidal cells are present in the basal epithelium. So the cells contain intensely basophilic nuclei and situated away from the basement membrane. It is called Pallisaded cells. So basophilic nuclei that is situated away from the basement membrane. And the suprabasilar layer are made up of polyhedral cells. There is a mitotic activity is also seen, desquamated keratin within the cystic lumen, and presence of multiple small microcysts within the connective tissue of the cyst. So these multiple small microcysts are called as daughter cyst or satellite cyst. Daughter cyst or satellite cyst, because these cysts it has more recurrence rate. So daughter cyst are microcyst present within the connective tissue of the cyst. So mitotic activity also seen. So this picture showing there is a 6 to 8 layers of 8 layers thickness. It is a keratinized stratified odontogenic epithelium, and there is a basal layer, and it has contained tall columnar or cuboidal cell. There is a tall columnar cells, and the basophilic nuclei are present, and it is situated away from the basement membrane, and there is a epithelium and connective tissue, that is a flat surface, and it is a V-shaped retipex. So the cystic epithelium shows dysplastic changes, sometimes hyalinization, melanin pigmentation, mucous metaplasia, hyaline bodies. These are the dysplastic changes present in the cystic epithelium: hyalinization, melanin pigmentation, mucous metaplasia, and hyaline bodies. Next, moving on to the special investigations. What are the special investigations for the OKC? First one is computed tomographic scan, that is CT scan, and DNA analysis of the lining epithelium, and scanning electron microscopy, that is SEM, scanning electron microscopy, transmission of electron microscopy, immunohistochemistry, and the enlargement of the cyst. So these are the special investigations for OKC. Next, moving on to what are the treatment for OKC. The treatment is done by surgical enucleation or marsupialization. Surgical enucleation or marsupialization, and curettage and peripheral osteectomy, and simple excision, and coronized solution. So coronized solution, it is not done alone, it is conjunction with the excision, and enucleation and cryotherapy. So most commonly we use surgical enucleation or marsupialization, and also use coronized solution along with the excision, and cryotherapy also used with enucleation. So these are the treatment options for OKC. Mostly we have to use surgical enucleation and marsupialization technique. This picture showing the treatment procedure. There is, we remove the whole part along with the tooth also removed. So this picture showing the facial asymmetry on the right side of the face. So this patient having Odontogenic Kerato Cyst. So there is a swelling on the right side of the face. It produces facial asymmetry because it is a large cyst. And the second picture, this picture showing the large OKC involving on impacted canine with unilocular and scalloped borders. So it is a unilocular and it is around the impacted canine. And the third picture is showing the intraoral view showing obliteration of the labiobuccal sulcus. So there is an obliteration, there is no clear sulcus depth. So intraoral view showing obliteration of the labiobuccal sulcus. So this picture, fourth picture showing the degloving incision marked 6 to 8 cm away from the attached gingiva. So there is a 6 to 8 cm away from the attached gingiva. We have to give degloving incision. And the fifth picture is showing the small perforation with exposure of the impacted canine. So we have to give some perforation. We have to cut the bone around that area. So there is this picture showing that canine tooth are seen. So this picture is the histology. So composed of thin irregular bundles of collagen, contains islands of epithelium that may represent daughter cyst. So there is a daughter cyst also present. So the seventh picture showing the lining was removed intact. It is a lining. Cyst lining is here. So it is a cyst lining removed from the OKC. And 8th picture showing the extraction of impacted canine. So we have to remove the canine. This is the after curettage betadine soaked gauze packed placed in the cavity. So it is a betadine soaked gauze that is placed in the cavity. It is the extraction of the impacted canine. It is the impacted canine. So we have to, after curettage, we have to place the betadine soaked gauze. And recurrence, why it is most commonly recurrence occur in OKC, this is the reasons why. So first one, satellite cyst or daughter cyst and new cyst formation and keratinization pattern and nature of the cyst lining, because it is highly active, because it has mitotic activity, so it produces recurrence. And basal layer of the oral epithelium and conservative surgical procedure.